Minda, and I'm with the lecture series on the lungs, gross anatomy of the lungs. So our last lecture we had discussed the impressions and the grooves on the mediastinal surface of the lungs, and I said you need to pause and be able to understand which structures groove which part of the mediastinal surface of the lung, because that's examinable in your steeplechase practical exams. So we move to the diaphragmatic surface of the lung. This is the lower portion. It's usually concave and forms the base of the lung, usually rests on the domes of the diaphragm. So remember, the right diaphragmatic surface will be deeper or more concave than the left because the liver sits below the right lung. And then the diaphragmatic surface is usually bounded by a thin and sharp margin on the inferior border, and that usually projects into the costodiaphragmatic recess. This is the potential space in the pleura between the costal surface of the pleura and the diaphragmatic surface of the pleura. So this inferior border of the lung on the lateral and posterior aspect, it usually is able to project into the costodiaphragmatic recess of the pleura. So this just shows you that the right lung is higher than the left because of position of the liver on the right that tends to raise it. This is the diaphragm, this is the liver. So this is the base, the diaphragmatic surfaces of the lungs. The borders of the lung, we say we have three borders: the anterior border, and this is the margin between the costal surface and the mediastinal surface of the lung, and it's usually they meet anteriorly and overlap the heart. So you have the cardiac notch that indents this anterior border of the left lung. So this is the anterior border between the costal and the mediastinal surface. Then the posterior border will be formed by mediastinal and the costal surface, while the inferior border is formed by the costal and diaphragmatic surfaces. So the inferior border separates diaphragmatic surface from costal and mediastinal surfaces, while the posterior border is formed by when costal and mediastinal surfaces meet posteriorly. Okay, costal and mediastinal surface meeting posteriorly, while anterior border is formed by costal and mediastinal surfaces meeting anteriorly, while the inferior border is where mediastinal, diaphragmatic, and costal surfaces meet inferiorly. So the posterior border is close to the thoracic vertebra, remember that. What are the variations of the lobes of the lung? So a lung can have an extra fissure, or a fissure may be absent. The left lung can have 3 lobes, the right lung can have only 2 instead of 3. But the most common variation is what we call azygous lobe, which is an accessory lobe. So how does it come about? In 1% of the people, the azygous vein acts over the apex of the right lung. You can see the azygous vein here. Over the apex of the right lung, it will arc there, okay, and not over the right hilum. Ideally, it should be, remember the mediastinal surface of the lung, we could see the arc of the azygous vein on the right lung. But if it does not arc towards the right lung, it goes and arcs on the apex of the lung. Therefore, it isolates the medial part of this apex from the lateral part. So this medial part is what you call the azygous lobe. And you can see the azygous vein here. So this is your azygous lobe. This is a azygous vein that has arced on the apex of the lung. And from here, you can appreciate you have this portion. There's the space here with your azygous vein, and this is your azygous lobe on chest X-ray. So how do you physically examine the lungs? There is the auscultation with a stethoscope. You listen to how air enters and leaves the lung, and you have to auscultate from the apices to the bases of the lung, both on the anterior thoracic wall and the posterior thoracic wall. So the apices will be mainly auscultated above. You can even auscultate above the clavicle, while the bases can be auscultated on the posterior thoracic wall at T10 level. We have percussion, where you just tap the thorax with your fingers to detect the type of sound, and that will tell you whether the lungs are filled with air. You'll hear a resonant sound. If the lung is filled with fluid, like in pleural effusion, if the pleural space is filled with fluid, you'll hear a dull sound. And if the lung is consolidated because of pneumonia, it will feel solid. So when you percuss, you'll hear flat sound. So when you auscultate the apices above the clavicles there, this is how you auscultate. You first auscultate here, 1, 2, 3, 4, 5, 6, 7, 8. So that's how you listen with your stethoscope. Then at the back, this is the order which you follow with how you place your stethoscope. You ask your patient to take a deep breath in and a breath out, and you auscultate. Then percussion, this is how percussion is done. So when you hear a resonant sound, it's air. When you hear a dull sound, it tells you there's fluid accumulation. So again, you have to do from the superior portion going downwards. You have to examine all the parts of the lungs on both anterior and posterior thoracic walls. So we have what you call triangle of auscultation. It's the only part of the back that has no muscles. So it becomes best for auscultation because you hear sound better. If you place the stethoscope there, you're likely to hear the breath sounds from the lung. So what are the boundaries of the triangle of auscultation? On the medial part, you have the lateral border of trapezius. On the medial part, this is medially, this is your trapezius muscle, you have the trapezius. Then laterally, you have the vertebral border of the scapula. Laterally, you have the vertebral border of the scapula. So this is your triangle here. So vertebral border of the scapula, and inferiorly, you have the superior fibers of the latissimus dorsi. The superior or horizontal fibers of latissimus dorsi. You can see here. So this is your triangle of auscultation where there is no muscle cover. So the breath sounds are heard very appropriately. Then we have other applied aspects. When you have lung cancer and it involving the phrenic nerve. Remember, phrenic nerve passes on the mediastinal aspect going to the central part of the diaphragm. So it innervates the diaphragm. It gives motor innervation to the central part of the diaphragm. So if lung cancer involves the phrenic nerve, there will be paralysis of the diaphragm. The recurrent laryngeal nerve is very close to the apex of the lung. So when you have cancer, the apices of the lung, it can involve this nerve. And remember, this nerve innervates all the muscles of the larynx except the cricothyroid muscle. So if you're going to involve the nerve, it will lead to hoarseness of voice because your vocal cords will be paralyzed. Yeah, these laryngeal muscles help to move the vocal cords. If the nerve is involved, there will be hoarseness of voice. So then we start with the airway. We have the larynx that contains horseshoe and C-shaped rings of cartilage, and main cartilages are actually made up of hyaline, such as thyroid and cricoid cartilages. But we have other cartilages of the larynx that are made up of elastic cartilage. Remember, you have the arytenoid, corniculate cartilages apart from thyroid and cricoid. So next, air will move from the larynx into the trachea. So the trachea is within the superior mediastinum. The trachea has two portions. You have a cervical portion and a mediastinal portion. So the mediastinal portion is in the superior mediastinum, and it constitutes actually the trunk of the tracheobronchial tree. It forms the trunk. You can see it here. Other details of the gross anatomy of the trachea is described on the lecture in the superior mediastinum. Remember, we said the trachea has tracheal rings, C-shaped, that the C is completed posteriorly by a smooth muscle which you call trachealis, and the cartilage is mainly hyaline cartilage. Trachea is lined by pseudostratified columnar ciliated epithelium with goblet cells, and the cervical portion is supplied by inferior thyroid artery, while the mediastinal portion of the trachea gets blood supply from the neighboring bronchial arteries, the esophageal arteries, mediastinal arteries, and so on and so forth. So the trachea bifurcates at the sternal angle of Louis, which there is a line that passes from sternal angle of Louis to T4, T5 junction, and this line is what divides the mediastinum into superior and inferior mediastinum. So the trachea bifurcates at the sternal angle of Louis to form the two bronchi, right and the left bronchi. And of course, the innervation of the trachea will be by autonomic, sympathetic, and parasympathetic, and the lymphatic drainage will be mainly by the tracheobronchial lymph nodes. So the primary bronchi, we have the trachea bifurcating into two main primary bronchi. And remember, the right main bronchus is wider, shorter, and runs more vertically than the left. Yeah, so it's wider, shorter, and runs more vertically. Why? Because it passes directly to the hilum, while the left passes inferolaterally and goes inferior to the arc of the aorta and anterior to the esophagus and thoracic aorta before it reaches the hilum. So it makes it, it's not more vertical, it has a longer course. So it goes inferolaterally, then passes inferior to the arc of the aorta, then goes anterior to the esophagus and the thoracic aorta before it reaches the hilum of the left lung. So the right lung, this is the right main bronchus and the left main bronchus. So the right one is shorter, it's wider, and it's more vertical or more inclined with the trachea, but the left one deviates from the tracheal line with a greater angle than the right. So the right is wider, more vertical, and shorter, and it's supported by C-shaped cartilages, both of them, but the angle the right bronchus deviates from the trachea is smaller than the angle by the left bronchus. Bronchi, you move to the secondary, then to the tertiary bronchi. So the bronchi and other roots of the lung, they branch within the lung. So together with the pulmonary arteries and veins at the root of the lung, the bronchi will branch within the lung to form secondary and tertiary bronchi. And the secondary are what supply a lobe of the lung. So right lung has 3 lobes, so it will have 3 lobar bronchi, while left lung has 2 lobes, so it will have 2 lobar or secondary bronchi. So each of these will supply a lobe of the lung, and then later divide into segmental bronchi. Segmental bronchi are what you call the tertiary bronchi, and these supply a bronchopulmonary segment. Tertiary bronchi supply bronchopulmonary segments, while secondary bronchi supply the lobes of the lungs. So this just shows the branching from the trachea to the main primary bronchus to the secondary bronchi before we get to the tertiary or the segment. Again, this is the branching pattern from primary to secondary, then to tertiary before you get to the bronchioles. And what do you notice? From the larynx, as you keep branching, the amount of cartilage reduces from cartilage plates, from cartilage rings to cartilage plates to reduct to the alveolar. There's no cartilage. So you are sort of trying to thin the wall so that you are at the alveolar, you're able to achieve gaseous exchange because of a very thin barrier that will allow diffusion. You don't want cartilage close to the lung where gaseous exchange occurs. So what is a bronchopulmonary segment? Bronchopulmonary segment is a portion of the lung that is supplied by a segmental bronchus as well as tertiary branches from the pulmonary arteries. So it's usually pyramidal in shape. So you have a pyramid with the apices of the pyramid facing towards the lung root. So the apex of the pyramid faces towards the lung root and the base faces the pleural surface. So a bronchopulmonary segment is actually the largest subdivision of a lobe, and each segment is separated or delineated by connective tissue septa supplied independently by a tertiary bronchus and tertiary branch of pulmonary artery. So they are named according to the segmental bronchi that supply them. Usually they are drained by, again, a tertiary branch or tributary of the pulmonary vein. So why do you need to understand that these segments exist? Because they are surgically resectable. So if you have one bronchopulmonary segment with cancer, you can actually go and resect it without affecting the others because of they are separated or delineated by connective tissue septa, and because they function independently. They are supplied independently by segmental bronchi, pulmonary arteries, and pulmonary veins. How many bronchopulmonary segments do we have? 18 to 20 in number, whereby we have 10 on the right and approximately 8 to 10 on the left. So you can be told to write an essay on bronchopulmonary segments, and this is what you are supposed to describe. So this just shows you the branching pattern that a segmental bronchus with segmental portion of the pulmonary artery and pulmonary veins supply a bronchopulmonary segment. And these are the segments that are named based on, so you have on the upper lobe, you have an apical segment, posterior and anterior segment. Then a middle lobe has lateral and medial segments, while the lower lobe has superior, anterior, basal, and lateral. So you're not supposed to the features of a bronchopulmonary segment. This is what is expected of you. Everything that is in this slide is very important. Okay? And this just shows you what happens when you innervate and blood supply of the bronchopulmonary segment. So next we continue with the bronchial. So we've covered bronchi, primary, secondary, and tertiary bronchi with the bronchopulmonary segments. So we move to the terminal bronchioles. From the terminal bronchioles, they'll branch into respiratory bronchioles, into the alveolar ducts, alveolar sac, which are lined by alveoli. So you have your terminal bronchioles, respiratory bronchioles, alveolar ducts, and alveolar sac lined by alveoli. So the alveoli are the ones for gaseous exchange. So they are simple squamous cells that allow gaseous exchange, and usually they continue to develop until 8 years of age, and they're usually 300 million. So this is the histology of the lung. So you can appreciate alveolar ducts when they're lined by alveoli, which are simple squamous epithelium. What's the blood supply to the lungs? So you have pulmonary arteries and veins. So pulmonary trunk from right ventricle, they bifurcate at sternal angle of V to form right and left pulmonary arteries. Remember, they're carrying poorly oxygenated blood taken to the lungs for oxygenation. Okay, so each pulmonary artery will divide and follow the division of the bronchi. So from the main bronchus, they'll divide to lobar branches to segmental branches supplying the bronchopulmonary segments. So they run arteries and the bronchi, they branch simultaneously and run a parallel course. So this just to show you the branching of the pulmonary arteries. Pulmonary veins are 4, 2 on each side, 2 superior, 2 inferior, and they carry oxygenated blood from the lungs. Yeah, so pulmonary capillaries unite to form veins that empty into pulmonary veins, and this will run independently of the arteries and the bronchi. So they don't follow the arteries and pulmonary arteries and bronchi will course together, but these veins, they run independently. So they receive blood from adjacent segments and they run towards the hilum. The veins from the visceral pleura will drain into pulmonary veins, while parietal pleura will join systemic veins of the thoracic wall. So intercostal veins drain parietal pleura, while visceral pleura will drain into the pulmonary veins. Bronchial arteries supply the lungs, okay? So they bring nutrition to the lungs. Pulmonary arteries were bringing deoxygenated blood for oxygenation, while bronchial arteries are actually what supply nutrition to the lungs, visceral pleura, and the root of the lung. So you have 2 left bronchial arteries from the thoracic aorta and single right bronchial artery that's directly from the aorta. So these bronchial arteries also supply the esophagus, and the distal branches are able to anastomose with pulmonary arteries on the walls of the bronchioles and the visceral pleura. Remember, parietal pleura is supplied by the arteries that supply the thoracic wall. So intercostal arteries supply parietal pleura, while bronchial arteries supply nutrition to the lung roots, the lungs, and the visceral pleura. So this just shows you the bronchial arteries. So this is the bronchial artery here, branching, and the bronchial arteries on the superior and inferior parts. Okay. Bronchial veins will follow the artery, so they only drain the parts where the arteries supply, and mainly the proximal part of the roots of the lung. So the remainder of the blood is drained by pulmonary veins. So bronchial veins drain the proximal part of the root of the lung, but the remaining parts supplied by bronchial arteries, such as the visceral pleura, the distal components of the lung roots, as well as the lung regions, will be drained by the pulmonary veins. So the right bronchial veins drains into the azygous vein, while the left bronchial vein will drain into the accessory, hemiazygous, and the left superior intercostal vein. So just revisit the lecture on the posterior mediastinum and see what veins form. Bronchial veins also receive some blood from esophageal veins. So bronchial veins will drain the proximal part of the lung root and receive some blood from the esophageal veins. The remaining part of the lungs are actually just drained by pulmonary veins, including the visceral pleura, the distal components of the lung roots, and the peripheral lung roots. The lungs are drained by superficial and deep plexus. So the superficial, they are towards deep to the lymphatic, the visceral pleura, and they drain into bronchopulmonary lymph nodes at the hilum of the lung. So bronchopulmonary lymph nodes are also called hilar lymph nodes, while the deep lymphatics follow are in the submucosa of the bronchi and in the peribronchial connective tissue. So superficial lymphatics are just below the visceral pleura and they will drain into the bronchopulmonary lymph nodes, while the deep lymphatics are in the submucosa of the bronchi and connective tissue around the bronchi, and this will drain the structures from the root of the lung. So you have deep lymphatics, eventually will go into pulmonary lymph nodes along the lobar bronchi, and from there they get to the bronchopulmonary lymph nodes, which are the hilar lymph nodes. So you can appreciate here the bronchopulmonary lymph nodes, the tracheobronchial lymph nodes here, okay, subpleural lymphatic plexus, paratracheal lymph nodes. So all these will drain. So the deep below the pleura to bronchopulmonary lymph nodes. The lymphatics in the submucosa and the peribronchial connective tissue will first drain into pulmonary lymph nodes along the lobar bronchi before they follow the vessels to get into the bronchopulmonary lymph nodes at the hilum of the lungs. So from there, superficial and deep lymphatics are at the hilar lymph nodes, then they get to the tracheobronchial lymph nodes before they get to the bronchomediastinal lymph node, and these terminate at the junction between subclavian and internal jugular vein. Okay, so superficial and deep lymphatics to the hilar, to tracheobronchial, to bronchomediastinal, and then terminate at the by emptying into the vein, the place where internal jugular and subclavian veins meet to form the brachiocephalic vein. So the lower lobe of the left lung drains into right superior tracheobronchial nodes and later follows the right side pathway. So the left lung on the lower lobe, they will drain on the right side. Then you have bronchomediastinal trunks, the right and the left. So the right one will merge with other lymphatic trunks to form a short right lymphatic duct, while the left one terminates in the thoracic duct. Lymph close to the thoracic wall, so it will drain into intercostal, parasternal, mediastinal, and phrenic lymph nodes, while the lymphatic vessels from cervical, parietal pleura, the parietal pleura are the apices of the lung, they will drain into the axillary lymph node. So the lymphatic drainage of the lung is very complex and you need to understand it because you can be asked to describe in detail what is the lymphatic drainage of the lung. So you should be able to describe how superficial is deep to the visceral pleura into bronchopulmonary lymph nodes, and the deep is on the submucosal bronchi and the peribronchial connective tissue to drain into the pulmonary lymph nodes before getting to the bronchopulmonary or hilar lymph nodes. So from bronchopulmonary lymph nodes, these lymphatics go to tracheobronchial, then to bronchomediastinal lymph trunks, then into the junction between subclavian and internal jugular vein. The right bronchomediastinal tract will form a short right lymphatic duct, while the left terminates in the thoracic duct. Then we've said parietal pleura will be drained by the lymph nodes on the thoracic wall, such as intercostal, parasternal, mediastinal, and phrenic lymph nodes, while few lymphatic vessels from the apical part of the parietal pleura will drain into the axillary lymph nodes. What is the innervation of the lungs? You have parasympathetic from the vagus that will cause the smooth muscles of the bronchial tree to constrict and inhibit vasodilation of the pulmonary vessels. Parasympathetic also stimulates the secretion of glands in the bronchial tree. So parasympathetic is from vagus to cause smooth muscle constriction, secretion of glands, and inhibit vasodilation of the pulmonary vessels. So this image just shows you this is a sympathetic ganglion, will give branches to the lungs, but remember the vagus nerve will also give the parasympathetic component to the pulmonary plexus that will supply the lungs. So you have reflexive visceral afferents from vagus. They'll get to the bronchial mucosa, okay? They'll get to the bronchial muscles, to the connective tissue, to the pulmonary vessels, arteries, and veins. So they're able to make the lungs respond to tactile sensation leading to cough reflexes, stretch reception by the muscles, pressure receptors to the pulmonary arteries, therefore they make the arteries sensitive to blood pressure, chemoreceptors to the pulmonary veins make them to be sensitive to blood gas levels. So this is basically how the reflexes of the vagus nerve in the lungs are achieved. So if there's anything irritating the bronchial mucosa, it will cause cough. If there's anything that will cause stretch, if you stimulate it, will cause stretch of bronchial muscles. If there's pressure receptors are stimulated, they're sensitive to blood pressure. And if blood gas levels change, you have the chemoreceptors that are able to respond to this, and all these are innervated by the vagus nerve. So we have visceral pain fibers from visceral pleura and the bronchi. They follow the sympathetic fibers, while the pain fibers from the trachea will follow the parasympathetic fibers of vagus. So from the lungs, the pleura, visceral pleura and the bronchi, they follow sympathetic, and the trachea, pain fibers will follow parasympathetic of vagus. We have sympathetic from the sympathetic ganglion, will cause bronchodilation of the bronchial muscles. They will cause vasoconstriction of the pulmonary vessels, and they will inhibit mucus secretion from the glands in the bronchial tree. So when you stimulate sympathetic from the sympathetic ganglion, there will be bronchodilation. The bronchi will dilate because the muscles will be inhibited. Pulmonary vessels will constrict, and glands within the bronchial tree will decrease in secretion. So you will inhibit alveolar glands of the bronchial tree from secreting mucus. So parietal pleura is innervated by intercostal and phrenic nerves. So the costal surface will be innervated by costal nerves, while the central parts of the diaphragmatic pleura and the mediastinal pleura are supplied by the phrenic nerve. So what are the applied aspects? Because the right bronchus is wider, shorter, and more vertical, foreign bodies get to dislodge towards the right side. Then, because of the septation and the connective tissue, after aspiration, depending on which airway the foreign body has obstructed, it can lead to that segment to be to collapse because no air is entering the segment. So that's what you call segmental atelectasis, when the segment collapses because of aspiration by a foreign body that blocks a segmental bronchus. Then the bronchopulmonary segment can be resected when it's affected by disease or cancer, that's segmentectomy. You can remove a whole lobe, that's lobectomy. And if a whole lung is affected, you can actually do surgery to do pneumonectomy, where a whole lung is removed. Pulmonary embolism is when you have emboli, either fat, air, or blood clot into the pulmonary vessels. Pleuritis is the inflammation of the pleura, and you can have referred pain from parietal pleura. Remember, parietal pleura gets somatic innervation. So the costal and peripheral surfaces of the diaphragmatic pleura, pain will be referred to the thoracic and abdominal walls. But remember, the central part of the diaphragmatic pleura and the mediastinal part of the parietal pleura, they are innervated by phrenic nerve C3, C4, C5. So the pain will be referred to the root of the neck and the shoulder. Remember, the shoulder has root value of C5 by the axillary nerve. Thank you very, very much.